So we'll move on to our next speaker, and it's my pleasure to invite Professor Jackie Smilg to the podium. Jackie finished her undergraduate studies at Wits. She went on to do the college exams. She then was awarded a PhD from Wits University. She's an adjunct professor and an honorary researcher at the University of the Witwatersrand. She currently works in private practice. She is a past president of BISA, and she is on the EXCO of Bogoza and president-elect. So, Jackie, to speak to us on all matters breast imaging. Thanks.
Thanks, Georgia, for that kind introduction. And thank you for the opportunity to address you on how breast imaging is facing the future. As we heard in the surgery talk, to go to the future, you've got to look back a little bit to the past. Mammography was basically introduced in the 1960s. I trained on xerography, which is that lovely blue image on the left of your screen there. And since then, we've had a lot of developments with different types of imaging. But mammography is still the gold standard for the early detection of breast cancer. We now have full field digital mammography, and it's a key modality for breast cancer screening and diagnosis. But its only problem is it provides morphological information only about the breast structures. It has limited sensitivity, ranging between about 30 and 80%, and limited specificity, and is severely influenced by the density of the breast tissue, both in that breast density is an independent risk factor for breast cancer, and that it can have a masking effect and making diagnosis extremely difficult. If we have a look here in the very fatty breast, you can see the cancer very easily, but as we progress through the densities, you can see how the breast density can mask it. So mammography on its own has its own limitations. Along came digital breast tomosynthesis 12 years ago. It was FDA approved as a modality in screening, and it has been widely adopted in the US as a standard of care now for breast imaging and screening, and has moved out across the world in that form. Digital breast tomosynthesis has also advantages and disadvantages. Advantages include its increased breast cancer detection rates, particularly in the denser tissue, and this decreases recall and false positive rates. But the disadvantages are that the interpretation time goes up. You've got significantly higher numbers of images to look at and to assess. And along with the multiple images goes an increase in the radiation dose of about 23 to 38% higher than digital mammography on its own. So if we do a review of the data, digital mammography versus digital mammography plus tomosynthesis, studies show that there's better visibility of cancers on the combination and a significant increase in cancer detection rates when compared to digital mammography alone. The recall rates are significantly reduced using the combination, and the false positive rates are reduced using the combination of both digital mammography and tomosynthesis. The next development was the synthetic mammogram or the virtual mammogram. The advantages here is it saves the acquisition of the 2D mammogram on its own, and it saves on dose. But the disadvantages are that it's inferior in spatial resolution to the traditional digital mammogram, and it accentuates high contrast images, but has a problem at the points of resolution threshold. So its adoption rate has been fairly slow since its introduction in 2013. If we look at a 2021 meta-analysis of synthetic mammogram and tomosynthesis versus digital mammogram and tomosynthesis, most studies in fact found that there were similar benefits in detecting cancers. So we know that the synthetic mammogram is actually an inferior image to the digital mammogram. The digital mammogram has a better resolution, but there is in fact support for either. So going on to contrast-enhanced imaging, this has added physiological information to the morphological information and data that we achieve from the mammogram on its own. Contrast-enhanced mammography, breast MRI, all work on the principle of the injection of contrast to aid in diagnosis. In breast MRI, we use gadolinium as the contrast agent, whereas in contrast-enhanced digital mammography, we use an iodine-based contrast agent, very similar to, or in fact, the one we use in CAT scanning. They have the same basic physiological principle. They image lesions with high neovascularity, where there's extracellular leakage of that contrast. And they say they have the same basic advantages and disadvantages. They have a high sensitivity for cancer detection, but they are also false positives, as we do know well that many benign lesions enhance as well. From the patient's perspective, a disadvantage is that they both involve an injection of contrast. but unlike the mammogram on its own, the imaging is not affected by breast density. Contrast-enhanced imaging works on the principle that the tumor secretes vascular growth, epithelial growth factor production that leads to angiogenesis, and that angiogenesis and neovascularization is what is being detected with the administration of contrast. So how does their digital clinical performance fare? Contrast-enhanced 2D mammography has a higher sensitivity than just 2D or tomosynthesis on its own. Contrast-enhanced mammograms and breast MRI show comparable performances. Contrast-enhanced mammography and breast MRI have comparable accuracy in tumor sizing. And we find often that patients prefer the contrast-enhanced mammography over the breast MRI, often due to the claustrophobia associated with the MRI. But overall, breast MRI still has a higher sensitivity and a higher probability of absolutely excluding breast cancer than does contrast-enhanced mammography. So when we compare contrast-enhanced mammography to MRI, the advantages are that it has a lower cost associated with it. It is a much faster procedure, although that is being challenged by the ultra-fast MRI, as I'll discuss later. It has a faster reading time, and it also allows for good imaging of microcalcifications because of this low-energy image that's generated during the performance of the contrast mammography. The disadvantages of contrast mammography is that you don't get imaging of the two breasts at the same time. We don't get the time activity curves to assess. It does involve radiation and also the potential side effects of the iodinated contrast agents. This is what contrast mammography does in pictorial form. It highlights the cancer. The cancer is there, but on normal digital mammography, we may not be able to see it very well. Giving the contrast makes it stick out like the red apple. Contrast-enhanced mammography is the imaging of iodinated contrast agent using mammographic imaging equipment. It's a dual energy spectral mammography technique, and it gives both functional and morphological information, and it improves the lesion conspicuity, especially in the dense breast. On the left, you can see the normal mammogram, the 2D image, and on the right, the contrast subtraction image where the cancer is very easily detectable. Contrast mammography was FDA approved as an adjunct following mammography and ultrasound and to localize a known or suspected lesion since 2011. It uses this dual subtraction technique. We don't actually see the contrast on the high or the low images, but when we subtract the one from the other, we get a subtracted image that shows where the contrast has been added. We only read the low contrast imaging, which is essentially looking exactly like a normal digital mammogram, and the subtraction images. So the low energy images, like the mammogram, give morphological information, and the subtracted images now give functional information in addition. Technical limitations of contrast mammography are that there are blind areas in the field of view, particularly on the edges of the breast and in the axillary tail. We don't get the kinetics of MRI studies. We can't use them particularly much in prosthesis breasts. There are artifacts, and there are the risks of the contrast media, and also that radiation exposure. It's up to 81% higher than the full field digital mammogram, but it's still well within the normal acceptable limits set by the Radiation Standards Board. The false positives from contrast mammography are very much like MRI false positives. We get artifacts, we get the background parenchymal enhancement. Depending on the hormonal effect on the breast, we can get significant enhancement. The B3 lesions that you heard about earlier, some of those can actually enhance, giving us issues of interpretation. Intramammary nodes, normal fibrocystic change, inflammatory change in the breast, and fat necrosis, all known to enhance with contrast. False negatives on contrast, again, are artifacts. The background parenchymal enhancement can mask the sensitivity of picking up small lesions in the breast. Lesions beyond the field of view are particularly difficult and may be missed on contrast mammography. And we know that there are certain cancers, particularly the mucinous ones and the in situ ones, that may not show particularly much enhancement, leading to false negatives. And Paget's disease also often associated with false negative. So the clinical applications of contrast mammography, it's an alternative to breast MRI, particularly to evaluate difficult to interpret mammograms. We use it hopefully to monitor effectiveness of drug therapy, identify potentially undetected malignancies and extent of disease, particularly in the dense breast. So we know that if a woman comes in and we know that her density is such that it makes mammography interpretation difficult, those are the patients we may well offer upfront contrast screening to. High-risk screening is a potential for contrast mammography, although this is not yet FDA approved. And then obviously patients contraindicated for MRI, it's a good alternative. We use it often to also evaluate discordant findings when we have mammography and ultrasound assessment. What is the use of contrast-enhanced mammography in the evaluation of microcalcifications? The conclusion on this is actually that it's only slightly improves the diagnostic accuracy of the calcifications, and it doesn't really add much value to the surgical decision-making process. So here's an example of contrast mammography and discordant findings. On the left, we have a mammographically spiculate suspicious lesion overlying the pectoral muscle at the back, and not much anteriorly in the dense tissue. Tomosynthesis added to that assessment now shows us that there's a potentially spiculate lesion hiding in the dense tissue anteriorly, but that lesion couldn't be really identified on sonar. So we had discordant findings between a sonar and a mammogram, put contrast on top of it, and you can very eloquently see how that second malignancy now jumps out at you on the right-hand side, the right image there with the subtraction technique. In the MRI contraindicated setting, example of this was a female patient with a pacemaker, and she had skin irritation, which she put down to the pacemaker. Normal mammogram shows a spiculate density posteriorly towards the pec muscle on that side. Tomosynthesis views again confirms the suspicious nature of this. Obviously, due to the pacemaker, she's not a candidate for MRI assessment. Using contrast mammography, we can see in the second to last right image the pre-chemo assessment of that image, and then the post-chemotherapy assessment of the response to treatment in a patient that would otherwise not be able to have this kind of assessment. So in evaluating extent of disease and also neoadjuvant chemotherapy response, we've got a very dense breast density on the normal 2D mammogram. The 3D tomosynthesis slices show a spiculate lesion, but we're really not clear on the extent of that disease. Putting contrast into that breast, again, pre and post chemo, gives us a very eloquent assessment of that breast. Areas of further research: contrast-enhanced tomosynthesis is very close on the horizon. It's still mainly in trials with very limited clinical study, but it's certainly something to look forward to in the near future. Along with contrast tomosynthesis studies also comes contrast-enhanced mammography biopsy. This works on the same principle as MR-guided biopsy, but it's cheaper, faster, and more accessible. The limitations, again, would be potential allergy to the contrast media, breast implants, and then possible renal dysfunction, which may prohibit the use of contrast material. Studies have shown that the contrast remains within the breast tissue for about 30 minutes after the contrast injection, allowing this procedure to become feasible, and that it is even often visible within the specimen X-ray of the biopsy samples, confirming the validity of the biopsy site. So that's something that I'm hear from the vendors is very close to coming to us on the floor. MRI breast is a dynamic study of the tumor vascularity, very much the same as contrast-enhanced mammography. We all know very well MRI, it's been with us for a long time. It looks at the increased uptake and washout of contrast in areas of increased permeability. What's now being investigated, multiparametric MRI. The first of these is ultra-fast sequences. Traditionally, we start doing MRIs at 1 minute and we image for the 5 to 8 minutes following that. Abbreviated sequences have been done looking only at the 1 minute image, but now ultra-fast sequences are being done in that first minute. Imaging every 3 seconds for the first minute is giving us a lot more information about malignancies. Many malignancies have been shown to enhance within 10 seconds of that contrast arrival. This will significantly cut the time frames needed for MRI assessment if we can do just the first minute of MRI assessment. Another of the multiparametric MRI features that's coming up is diffusion. This is a marker of cellularity. It is fast and easy to acquire, and it actually doesn't require contrast injection in the patient. Low ADC values equate to an increased cellularity, so malignancies show decreased diffusion because of their increased density. The advantages of MRI: it's multiplanar, it has a high spatial resolution, it has dynamic contrast enhancement related to the angiogenesis. We can add diffusion there looking at the cellularity, and it is a quantitative analysis with imaging markers of tumor biology. 3 Tesla MRI now increases temporal and spatial resolution and resulting in the detection of smaller and smaller lesions. Vacuum-assisted biopsy, vacuum-assisted excision, we've had discussions, I think, earlier, there for the B3 lesions, and I won't really linger on that. Just to say that tomosynthesis-guided VAB is shown to be significantly superior to stereo-guided VAB, as it allows the full detector size to be used for imaging, and it provides immediate depth information for the lesion without triangulation. Automated breast ultrasound can be added to the assessment of mammograms, particularly in patients with dense breast tissue. This is an FDA-approved adjunct as a supplemental screening tool in dense breast since 2021, and it is done in conjunction with full-field digital mammograms. Advantages here are increased cancer detection rates, increased sensitivity, and decreasing recall rates for mammographic interpretation only. But the disadvantages are that it's limited due to incorrect techniques, which may cause false negatives, artifacts, and the static images may also increase false positives at times. Just to add to our armament, although not very commonly used in the screening or diagnostic setting at the moment, is the molecular breast imaging. Nuclear medicine techniques that utilize a conventional gamma camera or a dedicated breast gamma camera to provide high-resolution functional images of the breast. And the current studies with molecular breast imaging have used technetium sestamibi, which is an approved agent for breast imaging. Molecular breast imaging was cleared for safety by the US Drug and Food Administration in 1999, and indications are possibly as a supplemental screening tool, preoperative staging with newly diagnosed cancers, evaluation of response to neoadjuvant chemo, detection of local breast cancer response, looking for breast cancer primary in patients with known metastases, when there's an unknown primary, and it may be used as a problem-solving tool when conventional imaging is indeterminate. Positron emission mammography, it's not available here in South Africa, but just to complete the picture, it's currently under clinical investigation in hopes of improving the sensitivity of breast cancer screening. Again, some indications for it, but certainly with the higher radiation dose associated with this to the patient, it's not likely to become into popular or common use in any time soon. To finish up, artificial intelligence has a huge role to play in radiology because our specialty is so technology and equipment driven. It currently helps radiologists to achieve faster turnaround times. It potentially delivers more accurate results by prioritizing cases, highlighting areas of concern in real time and identifying calcifications, architectural distortions, and masses, and highlighting this for the human assessment. It reduces the amount of time spent on interpretation, which can reduce reader fatigue. It can alleviate the impact from a global radiology shortage, and it can counteract the increased volume of reading coming from those tomosynthesis images that we now produce. A study a few months ago coming out of a multi-university team in the US found that AI was able to outperform the standard clinical risk models for predicting the 5-year risk of breast cancer in a study of thousands of mammograms. The study's authors drew on a cohort of just over 12,500 women in North Carolina who had mammograms performed on them in 2016. Using this group of imaging, the researchers gave them a risk score for breast cancer over a 5-year period using 5 AI models, 2 academic algorithms, and 3 commercially available algorithms, as well as the Breast Cancer Surveillance Consortium risk model. And the results were skewed heavily in favor of the bots, which were able to pick up on missed cancer indicators, despite that the researchers actually didn't know how the bots did it. So the full breadth and depth of the technology's potential is yet to be realized in radiology. In many ways, AI is poised to bring out the next era of groundbreaking advancements in mammography. So watch this space. Thank you.